of these tests are 100%. You have to remember that. Okay, bounce on. I'm going to have you scoot up just a little bit more. And what we're looking for here is some joint mice in there, or something that's keeping the knee from fully extending, right? So we're just going to lift this up, and I'm going to just let it fall back down. And it should fall nice and cleanly. If it doesn't go into full extension, or if there's maybe like a rubbery end feel or something that doesn't fully lock on, then we're going to think two things. Meniscus, joint mice, which usually comes with like an OCD, right? Right? Let's see if this. Okay. Next.
McMurray.
Hi, Molly. What's that?
McMurray.
McMurray's test. We just did McMurray's. What we want to do is fully flex the knee primarily. You can bring the hip up to about 90, and then we're going to palpate the joint, and we're going to internally, externally rotate, right, along the joint plane. Now, if that causes a painful clicking, the way you turn the heel, then that's enough. Okay? If it doesn't, then we're going to use varying degrees of internal rotation, external rotation of the foot with varying degrees of various pressures of varus and valgus stress. So I'm going to externally rotate, and I'm going to add some valgus stress, and then I'm going to keep it externally rotated, and I'm going to add some varus stress. Okay? So everybody got that? Then I'm going to turn the foot the other way, internal rotation with some valgus stress, internal rotation with some varus stress. Okay? All the meniscus. It depends on which way the heel is turned. We done?
Thessaly.
Thessaly test. Thessaly is the one that's for what?
Meniscus.
Meniscus. And this is the one where you have the patient stand up, and we're going to have them stand on their bad leg. Let's say that hers is her left one. And by the way, all these tests are done what?
Bilaterally.
Bilaterally. Good. Good. You're not going to forget that, are you?
Yeah, they will.
Yeah, they will. Okay. Squat and twist, right? And if that doesn't cause her any problems, then we're going to what? We're going to squat deeper and twist. Very good.
Come on,
and you're trying to see if there's any painful clicking or popping in that one. It's very, very effective test. Okay.
Patellar grinding test.
Patellar what?
Grinding.
Patellar grinding. This is also known as Clark's test. Is that right?
Clark's sign.
Clark's sign. The patient's leg is down. We're just going to milk the kneecap all the way down. She won't let me. Let this go. There we go. You're getting there. Okay. Then once you push the kneecap down, what are we going to do? You're going to have the patient contract and what? And hold it, right? Contract and hold the quad. If they can't do that, if there's pain, is that chondromalacia patella as well?
Yeah.
Okay. Something's going on underneath that kneecap. Next.
Fouché.
Fouché, that's when you think there's something going on underneath there again, right? And you're going to push down, and you're going to ask the patient if they like that, right? And if they say, oh, that doesn't bother them at all, then what are we going to do?
Rub it across.
We're going to grind it in, right? And then they're going to say, yeah, I hate you, or I like that dude some more. If they say that, then you're in trouble. Okay? What's next?
Allotment.
What is it?
Allotment.
Milk the fluid down into the knee, compress the kneecap in, and it should float back out if there's swelling underneath it. Okay?
Sure.
And the swelling could be any type of inflammatory situation. It doesn't say anything in particular on it, but it just says a fusion.
Chondromalacia patella.
Chondromalacia
fluid.
patella again. Something that's causing irritation. Causing
Drawer test.
what's the name of it?
Drawer test.
Drawer test. Right, we're going to bend this up. Everything's going to be, the knee's going to be at 90, the hip's going to be about 45, and we're going to stabilize and we're going to yank, right? And as we're yanking, nice steady yank. You're not like ripping it out. Nice steady yank. We're looking for displacement, what, at least 6 millimeters? Is that what it is? Looking for that stair step, and that's indicative of a
ACL.
Anterior cruciate ligament. As I push this back in here, now I'm looking for what?
PCL.
Posterior cruciate ligament. Okay, we're looking primarily for laxity on that. Next one is probably Lockman's, is that right? Okay, now some people do Lockman's, they just put this at 30 and they pull it apart, just like this. Most sources that I see, they go like this. They take it like this, and they push this back and forth like this. You can do either way, I don't care. Okay, again, cruciate ligament tear, anterior cruciate ligament.
Lateral pivot shift.
Lateral pivot shift test. This is one that usually confuses people. Only thing we're going to do with the lateral pivot shift, we're going to bring the patient's leg up. You're going to put your hand against the side of the patient's knee like this, right? Then you're going to add some valgus stress, and you're going to internally rotate the foot. Is that externally rotate the foot, move the knee medially? Is that the heel medially? Is that right or wrong?
Toes medial.
Toes medial. Okay.
With valgus stress.
So internal rotate with valgus stress, just like this. And then the only thing I'm going to do is what? I'm just going to flex it. And when you get to about here, it'll go clunk if you have a problem with that anterior cruciate ligament. Right? Very simple. Legs straight, add some valgus stress, internally rotate, bend the knee a little bit.
You're applying pressure through your thumb, right?
No, I'm not applying pressure, I'm just palpating with my thumb. Okay? And I'm palpating with my thumb because the fibula is attached to what? The tibia. And so I'll just be able to feel like clunking backwards. A little bit of valgus stress, internal rotation. And that should be a nice smooth movement. If it's not, you'll get that clunk inside.
Noble compression.
Noble compression. This is for what?
ITB.
IT band. So you bring the patient's leg up, put a lot of pressure on the IT band just about the insertion, just above the, it inserts down on the tibia, but you're going to be putting pressure right around the femoral condyle, lateral femoral condyle, just superior to it, a lot of pressure on it, and you're going to straighten this out, right? Pain should be under your thumb. Pressure, pain, and you know that indicative of an IT band syndrome. Am I saying these right? Yes. You guys keep tracking me good. Okay, what's next?
Slocums.
Slocum. This is for anterior or posterior rotational instability, right? There's a lot of ligaments that are involved in this, and so a bunch of them are listed. But I want for an answer what?
All of it.
Anterior medial rotational instability.
Anterior medial rotational instability.
Or anterior lateral rotational instability.
Okay. Anterior lateral rotational instability. So that's all I want you to tell me. You don't have to tell me all the ligaments. But you should know the ligaments because somebody else may want to know. Okay? So I'm going to turn the foot this way, toes in. And this is for anterior lateral rotational instability. And I'm going to turn the toes out. Anterior medial rotational instability. Okay, slocum.
Apprehension test for the patella.
Apprehension test for the patella. You're just going to move the patella. Which way do you have to move it? Medial, lateral, does it matter?
Both.
Move it both. And watch the patient's face while you're pushing it one way or another. If it causes them any distress, they may move their leg, they may, you know, give you a dirty look, or who knows what they're going to do, but they're not going to like it, right?
Wilson's.
Wilson's test. What's that for?
OCD.
OCD. Is this active or passive? Active. So this time I'm just going to turn the toes medially, right? And I'm going to have the patient straighten their leg. And as they're straightening their leg, they get to about 30 degrees and they say, wow, that hurts, because the tibial tubercle is putting pressure on that femoral condyle, right? And the only thing I need to do now is turn the toes back to neutral, and that should minimize take the pain away, right? Because I just removed the irritant. OCD.
Houston plica.
Houston plica test. We're going to bring the patient's foot up like this. We're going to again internally rotate. We're going to push the kneecap medially. We're going to palpate this. And as we're doing this, we're going to straighten this out, because what will happen is the plica is getting caught between the patella and that femoral condyle, right? And so I'm going to palpate. As I'm adding my valgus stress, it's not on the whole knee. It's just on the patella. Remember that. And then I'm gonna bring this down, and that should catch underneath there, and they should feel pain underneath there. Is there a clicking with that too?
Snapping, pain.
Snapping, okay. Is it a painful snap?
Snap and or pain.
Snap and or pain, okay?
For the ankle.
Anterior drawer of the ankle. So what we're gonna do is we're gonna stabilize here, and what we're gonna do is we're going to pull the talus forward, right? As we're stopping the tibia, we're pulling the talus forward, and if it comes forward, that's an anterior talofibular ligament tear, right? Okay. I can push it backwards, posterior talofibular ligament tear, right? Is that right?
Mhm.
Okay. Whichever way the talus goes, that's the side, that's the direction, anterior, posterior tear. Okay?
Thompson, Simmons.
Thompson-Simmons, that's the one with the patient is prone. And we're testing for the integrity of what?
Achilles.
Achilles tendon. Bring the patient's foot up like this. You can do this seated, but you're going to have to just make sure you hold pressure on the patient's foot and pushing it up while you're squeezing. Now, don't squeeze way down here. Get up closer up here. As you probably practice this on some patients, the higher you are, the better movement you get off the foot. Down here, you don't get as much movement, see? So you want to come up here. And so you're looking for that. You're also just going to do your visual and look for the integrity of the Achilles tendon. You'll be able to see it on the patient if it's intact.
Medial and lateral stability test.
Medial and lateral stability, the patient could be seated. The patient could be laying on their back. And we're just testing medial and lateral stability. Stabilizing on the tibia. So lateral stability, I'm going to stabilize on the tibia here, and I'm going to pull this across. Not all total inversion, but I'm going to pull across here. You're going to definitely invert, but you're trying to pull this across here as well. So that's testing the lateral stabilizers, which are anterior talofibular. So is it primarily the anterior talofibular on that?
Yeah.
No, it's not the deltoid.
For lateral, it's talofibular.
Yeah. Yeah, we're doing lateral strain here, right? We're straining the lateral side. So and I told you there's the 5 fibs I want you to remember right there. Not so much for now, but when you get into class. Anterior and posterior talofibular, tibiofibular, deltofibular stabilizer. And the medial stability, I'm going to press across this way, right? And I'm testing what?
Deltoid.
Suzanne.
Morton squeeze.
What's that?
Morton squeeze.
Morton squeeze. Just right, Lee?
Yep.
Just like this. Squeeze them across. Squeeze them across. We're compressing something usually between the second and third metatarsals here, right? Some type of tumorous type growth, benign, but nonetheless, it feels like a marble in there. They're unhappy. Causes pain, should be real specific.
Ankle sprain grinding.
Ankle sprain grading, you just know how to grade them. If they're hobbling in under their own without too much trouble, a little bit of a limp, probably grade 1. If they're really hobbling, it's a grade 2. If they're carried in, it's grade 3. You just open the front door and the back door. Right? Just keep walking through.
Burgers.
What's that?
Burgers.
Burgers. Burgers is one we're just going to pull the person's leg up in the air, right? We're going to hold it for 2 minutes, right? And we're going to look for some type of blanching in here. Some type of problem with what?
Vascular.
Vascular problem. What's that?
So the doctor does hold the straight leg raiser?
Yes, you're going to hold it. Yeah, the patient's not holding it. Or you could have your CA hold it. You have the next patient hold it. Okay?
And then
The next one is what?
Homans.
Homans, and the way we're going to do homans is not the way they do homans, but the way they do homans is they squeeze here, right, for pain. With this in dorsiflexion, that doesn't hurt them. Then we're going to maintain this and squeeze, right? But we're not going to squeeze. Anything we're going to do is have the patient's legs straight, and I'm not going to give you this on a test. And you're just going to put the patient through varying degrees of dorsiflexion. And if they say there's pain there, then you're gonna refer them.